Thank you very much, Rena, and a great presentations. Keep the comments and questions coming in. We have two excellent panelists. We're going to start with Dr. Amy Krawiec, who's Chief Physician of statewide HIV, hepatitis, renal transplant programs for the California Correctional Healthcare Services. Amy, please provide some perspectives. Thank you.
Hello, thank you for having me today. I'm going to talk about our HCV treatment programs in California state prisons. And we started, we're a very big program, very big prison system. We started in around 2017 with the more momentum for DAAs that were launched globally. And in 2017, at that time, we had 35 facilities and a population of about 132,000 patients, of whom 18,000 patients were RNA positive and needed treatment. So this was a daunting task, and as with most infectious disease programs, you can't do much without screening and testing. So in 2016, the Hepatitis C was added to the reception center intake lab opt-out screening panel. And our rates for screening with the opt-out are very high, from 90 to 97%. Believe it or not, in 2017, we did not have an electronic medical record. And so we had a massive rollout to our 35 institutions to finally come online. And 2018, we realized seeing patients one at a time really wasn't going to get the job done. So a central team was created to manage the entire treatment cascade. And 2019, we started having electronic tools that really were monumental in getting the job done in terms of registries, electronic forms, tracking and monitoring. And we also realized that our little central team was never going to be able to treat 18,000 patients. And so we began a hub and spoke model where we trained all the PCPs at all the institutions, and the primary care physicians started to treat hepatitis C. In 2021, we had a slowdown along with everybody else, but despite that, we had the ramp up very dramatically, actually, for our medically assisted treatment program during that time. And our focus in 2023 has been to continue ramping that up. That has also gone to a hub and spoke model for the primary care physicians being able to treat all the patients. And we are now starting a cognitive behavioral therapy rollout. And our plans for 2024 are to continue to expand access to substance use disorder treatment, which of course is the root cause of all of this. So this is just briefly to kind of show you the transition from where we were and where we are. So from 2017 to now, we now only have 33 prisons, and our population has gone down to about 97,000. Our entering antibody positivity rate through the reception centers is about the same, though, at 17 to 22%. And our prevalence in the whole population of HCV antibody positivity has also remained the same, from 20 to 25%. Our active RNA positivity in our population has gone down from 14% to 4%. And that is despite an incoming arrivals of 3,000 a month, about 36,000 a year to begin with, and now at about 2,200. Which is 26,000 yearly, and that's with a pretty sustained incoming RNA positivity rate of 12%. And so our eligible patients to treat, starting with the 18,000, is now at 3,700. The access model went, as we mentioned, from individual treatment to the PCP and central headquarters hybrid model. And the patients completing treatment, where it was really about 780 in 2017, has gone from 3,000 to a peak of 9,000 during the intervening years. And so in terms of patients that we have yet to offer treatment, there's only about 1,000 left. And our total number of patients that we've treated is at 33,437. None of this really matters, of course, if we don't address substance use disorder. And so we had this massive program that I was telling you about. And so you can see these numbers are very impressive. 95,000 patients screened, 37,000 patients assessed for their treatment needs, 24,000 plus evaluated for medical assisted treatment, and 16,000 actually provided MAT, and behavioral therapy started, and SUD treatment actually provided of any type in 22,704 patients. And our epidemiologist, Kim Lucas, who runs a lot of our epidemiology for us for hepatitis C, did some studies and was able to show that patients on MAT had a 33% reduction in HCV reinfections, and it was also associated with an increased SVR rate. So our program now, as you can see, we're pretty green. This is very high screening rates, very high annual retesting rate, very high timely treatment. Our SVR is on par with the community, and our ability to obtain an SVR test is high. Our substance use disorder screening is on the way up. I expect this to be in the 80s in a few months. And our reinfection rate started when we started our dashboard in, I believe, 2021, was at 6%, and now we're down to 4%. And that's all I have. Thank you.
Well, that's a lot. So thank you very much for going over that so quickly. That's a fantastic program. We have very few model programs in the correctional settings in the U.S., and this is certainly one of them. So thank you for giving us the highlights of that. Again, please have your comments and questions coming in. We turn to Julius. We can go over to his slide for his introduction. Julius Wilder is a hepatologist at Duke University. He's vice chair of the American Association for Study of Liver Disease Public Policy Committee, and has written several perspectives about health disparities in their and hepatitis elimination. So Julius, over to you.
Great, thank you very much. Happy to be here and honored to have the opportunity to participate in this important conversation. In the interest of time, I don't have slides, but I've been asked to come and speak to this idea of us being on the precipice of an amazing feat. We are actually at a point in time, and John certainly knows this as he's been a person leading this important discussion, is around actually moving forward towards hepatitis C eradication in the US. This, of course, being driven for the first time at the highest level of leadership in our country from the White House. You all may know that the Biden-Harris administration included in recent proposals that were submitted, a proposed 5-year program to eliminate hepatitis C in the US. This program, importantly, was developed through extensive consultations with key stakeholders within and outside government, including patient groups, physician groups, and federal agencies. What I'd like to do in a little bit of time I have here is just sort of speak to the 3 main priorities around this, because a lot of these priorities, quite frankly, speak directly to the point of this seminar, right? The idea of understanding the importance of health equity and access, and speaks to the very types of programs and incredible work that the people are doing in this space that we've talked about today. So one of the first priorities is going to be around testing. How do we do our diagnostic testing? Funds will be look to be used to leverage point of care hepatitis C RNA diagnostic tests. In the US, we are somewhat behind the rest of the world in this space. But being able to sort of develop that program here in the US, leveraging the Independent Technology Assessment Program, which is a collaboration between the Food and Drug Administration and the NIH to speed up clearance and approval of these point of care RNA testing, will allow us to really be able to do the types of screens that we need to be doing, primarily single visit screens that then will allow us to provide treatment and move forward. And honestly, when we think about trying to engage those communities at greatest risk, those underserved communities, having this type of technology available to us will be key in us being successful in moving forward towards screening as we think about eradication. Our second priority for this program will be around how do we think about the model, right, for getting these medications? How are we going to pay for this? And a key element will be a national subscription model to purchase these direct-acting antivirals for those who are particularly underserved, right? So, and this is where I love the idea, because we're really thinking about health equity now, right? And that's what we've talked about today, right? Who are those at greatest risk? You know, and we think about health equity, that's not about being equal, right? That's about making sure that we prioritize resources into those spaces where there is greatest need, right? And so a national subscription program that recognizes the importance of ensuring access for Medicaid beneficiaries, justice-involved populations, people without insurance, the American Indian, Alaska Native individuals who are treated through the Indian Health Service, prioritizing those types of populations through a subscription model will be of great benefit, moving us towards elimination and eradication of hepatitis C, particularly the fact that not only will that make these medications more affordable and improve access, but it's a win-win, because we know that our partners in industry will benefit from the volume in terms of purchased medications. And so we're excited about the idea of leveraging similar programs that have been successful in the VA, as well as been successful in Louisiana, to move forward towards eradication. The third major sort of piece to this proposal is around a really comprehensive public health effort to engage, inform, identify, and treat people with hepatitis C. And Dr. Price has spoken to this, and Dr. McMahon spoke to this, and Dr. Flores spoke to this. They've all sort of talked about, right, the importance of not just being in our health systems or in just sort of making these sort of decisions and writing prescriptions, but actually engaging the community, understanding from the community through a true community-based participatory research approach. What is the best way to test? What is the best way to screen? You know, what is the best way for us to think about how we actually engage and develop these programs? Knowing that may vary depending upon, you know, where people are, who people are, and the various factors impacting their access to healthcare. So universal screening, build an infrastructure for treatment, innovative models of treatment such as mobile units, community-based clinics, you know, as well as vaccine development will all be part of that third piece. So we're very excited about this plan and the potential opportunity for us to actually do something that's very, very unique and special, given the burden of this disease and how it really harms lives, right, in terms of liver cancer, cirrhosis, and we actually can do it with a plan like this, given the strength of the medications we have to cure hepatitis C. So I'll stop there and take any questions you all have. Thank you.
Thank you, Julius. See if there's any questions specifically for you. Not as yet. We did have.
We can ask the speakers to come on camera.
Yeah, but everybody go on camera. And Julius, I know, Amy, you may have some questions for the speakers. So let me get the round robin discussion going by Julius. You know, ask the question that came to mind for you as you heard the presentations.
I'm sorry, John, you said again, I didn't hear that.
Okay, just I thought just to get the discussion going among all the speakers, I thought maybe you had a question that came to mind for you as you heard the presentations that you would like to pose at this time for their comment.
So absolutely, yeah. I mean, I'd love to hear from, you know, from some of the presenters about, you know, because you all work in unique populations, unique communities, and you've built tremendous trust and engagement in these communities. I'd love to hear from you about how you did that. And when we think about hepatitis C eradication, the best way to do that. So that we can actually, you know, create impactful and sustainable programs in those spaces around hepatitis C eradication. Perhaps Dr. Price, the incredible work you've done, you can kind of speak about how you've done that.
Yeah, thank you. I mean, I think you've done so that was place just started and started.
Dr. Price, we are having trouble hearing you.
Oh dear. Is that? Can you hear me now?
It's better. Try. I think you're cutting out, but try again. Try again.
Let me hold on. I'm going to disconnect my VPN.
Oh, that's better. That's better.
Oh, that's better. Okay.
Go ahead.
Sorry, something weird happens with my Zoom when I mute. So what I was saying was that I could not have done this work without the NTEP CSF. Having that initiative together one of the roles of the group is to really make these connections, introduce people like me, who's, I'm a transplant hepatologist, to people in the community. I sat in on the prevention linkage and linkage working group to find out what the gaps were, where we needed extra work. When I outfitted our mobile van, I really relied very heavily on NTEP CSF to help guide me, to tell me where we should go, and also to train us how to do the rapid test. We don't do rapid antibody tests in the hepatitis clinic, right? In our regular clinic. So I think having those connections and just being open-minded, everybody was very supportive and collaborative.
Thank you. Amy, do you have a question, please?
Yes, I think it would be difficult to say who I would be interested in anybody's talking about this, but I feel like we're chasing our tail with hepatitis C. I mean, we're all focused on treatment, but without, can we do this without completely integrating global access to clean needles, without substance use disorder treatment, without really combining these two efforts? Are we going to be able to get the job done? And how would we maybe approach some discussions around smoking as opposed to injecting?
Well, that's great. I think it'll be difficult to treat our way out of this problem in the U.S. Be interesting to hear, Jennifer. And also, just from the program in Texas, we didn't hear a lot about harm reduction, access to clean needles, or perhaps I am not recalling it at the moment, but perhaps we could get a perspective from that program as well. And then, of course, Brian had a very low reinfection rate, and be interesting to see what's the status of harm reduction for people who inject drugs in Alaska. So let's go around the table on that one, please. Jennifer, please start.
Okay, yeah, so we do have access to clean needles in San Francisco. We do a lot of harm reduction counseling. This is I think a critical question, a critical issue. I agree. We've also had more of our deliver caravan patients who have died of overdose than died of a Hep C related complication. So, trying to get people access to MAT, like you mentioned, making sure people have access to clean needles is a huge priority. And we have a new navigation coordinator on the van who's working on, he's developed educational programs on harm reduction, which we're doing monthly now to our patient population. But I agree, it's critical importance.
Okay. Thank you. Bertha?
Yeah, so we do not specifically do the, how you mentioned, the clean needles, but there's many other programs who do in our community. However, all the PCPs usually do send the patients through mental health services or any other services that the patient may need.
What is the status of access to drug treatment in Texas for, let's say, Medicaid patients?
So they can get treatment. That's the first thing we actually do. We try to get them through Medicaid, but it's the ones that, for whatever reason, don't qualify, then we do the PAPs.
Mm-hmm.
Mm-hmm.
So
yes, but that is so our navigators, which is they do a wonderful job because they'll assist the patients in filling out all the forms and helping them through the process.
Thank you.
And that's where the navigation, I think it's a great help.
Okay, thank you. Brian, please give us an update on what the status of the issue of injection drug use in Alaska, hepatitis C in that population, and how you're seeking to address it for the Native American community, Alaskan Native community.
Thanks, John. Well, unfortunately, the state legislature, which is a bit on the conservative side in Alaska, has not really passed a bill to be able to distribute clean needles. And our needle exchange program in town, which is open to anybody, runs out of needles all the time. And so that's something we really need to solve. And the other thing that's really difficult is that we realized that during the COVID epidemic, the cartels more or less got into some of the rural villages And there's a lot of injection drug use in certain communities. For example, the first 83 persons that we screened in the rural villages, 13 of them were HCV RNA positive. And so that's quite high. Now that probably targeted, the community health aid practitioners targeted people who they knew were injecting drugs. But that's quite scary. And how do we get clean needles out to the villages? We have to get our tribal leaders to agree to doing that. I might mention one thing that pertains to a question that was asked. If you're an American Indian or Alaskan Native, your tribal organization can either get their funding and program through the Indian Health Service with all the restrictions, and or they can become independent. Now, our organizations in Alaska are taken over by the tribes and run by the tribes. They get some funding from the Indian Health Service, but they have to obtain the rest of it from Medicare, Medicaid, et cetera. It's easier to work with tribally run programs than it is, I think, in general. However, the Indian Health Service really aggressively has webinars or meetings every month or two, trying to work together globally through the U.S. to try to increase screening and treatment. So they're working hard on it. But I think the issue of clean needles is really one that really we have to address everywhere and make this. We need some legislation, both national and statewide legislation, to make it easier and get funding for clean needles, I think.
Thank you. Thank you very much. Any other comments on that? I thought I heard someone. The other thing, oh, sorry, go ahead. Is that Rena?
I was just going to follow up on Amy's presentation, where she talked about when you're doing HCV screening, you're also trying to screen for substance use disorder. I think those two probably can be implemented, or think about implementing them when you're doing screening in all these settings. Is that being done routinely, or is that something one has to think about implementing?
Is your question for me or for the speakers?
Anyone can answer that. It prompted me to think about from your presentation.
Yeah, it's easier for us because we know that the incoming substance use disorder rate is very, very high. And so global screening for substance use disorder, it's happening along with and independently of HCV screening. But personally, I think that that is the way to go, because it's the root cause. And so to start, we're trying to work on shortening our ability to get treatment, in as few appointments as possible, right? But we also might want to hit the door running with substance use disorder, or we're just, again, going to get reinfections. And so if we can get them plugged in very early on, I love this mobile clinic idea that Dr. Price mentioned, add the substance use to the mobile van, whatever it takes. But again, as she mentioned, it's all hands on deck.
Yeah, I would add to that, building off of the really great point Amy just made, is in the general hepatology clinics, I don't know that we are doing really intense screening for substance abuse the way we should, not globally. And it speaks to the benefit of what has been done, and some of the speakers have spoken to this idea of clinics that are really devoted to hepatitis C. And you can leverage in those settings multidisciplinary clinics where you have individuals and specialists there who can help navigate that conversation, provide appropriate resources, connect to care, and so forth, and linkage to care moving forward in that setting. And that probably is going to be an important discussion for a number of health systems that treat large population hepatitis C, to think about building as part of that infrastructure, to think about how we can truly do what Amy's doing, which is address this issue of chasing our tail with substance abuse and hep C, screening and treatment.
Thank you.
Yeah, if I could add in something about that. We do screen for substance abuse in the liver clinics, but most of that are going on in persons that don't get to liver clinic until they've got liver disease. But the other thing I think is important is screening for alcohol. And we use the Audit C, which only takes 30 seconds. And our aides hand that to the patient, and then by the time we walk into the room, that's filled out. And that is really crucial because in addition to curing hepatitis C, if we don't address other issues that affect a person's liver, including alcohol and NAFLD, and address that, we're going to make good progress, but we're not going to make complete progress and save patients from needing to go for a liver transplant if they develop liver failure afterwards.
No, thank you, Brian. And it makes me think of the slide of the definition of disparities that we had in front of us to kick off this webinar. And it really, it brings to mind this conversation here at the end. We have a major disparity in access to prevention for those who are injecting drugs or abusing others, overusing other substances like alcohol, as Brian mentioned. And we really have to be fully aware of this huge overlap of both of these epidemics and how they're feeding the HCV incidence, and we have to pay attention to that. Our collaborators at NIDA have had several webinars on this topic as part of this series, so I encourage you to go and get more information about that. But that's a lot of work needs to be done in that area to turn off the faucet of new infections as we seek to reduce prevalence through testing and treatment. And lastly, what else this webinar brings to mind for me is the importance of champions for hepatitis elimination. I think you've seen an excellent example of champions and what can be brought together through coalitions that the champion is a part of, either leading or participating in, but really having that champion to really put programs together, energize partners, and really make progress possible that would not have been possible otherwise. And I want to thank all the presenters for their work on that, and thanks to panelists Julius and Amy for their work also.